Hello everyone, welcome to our channel. Today we'll be discussing the gynecology rapid revision as part of the yesterday part 1. We have discussed obstetrics and part 2 we'll be discussing now. And guys, unfortunately Telegram has been banned. We can't access to the any of the files, and especially to all the paid subscribers of the Mission 200 plus. Guys, please do access the below link. In the below Google Drive, you can access to the PDFs of the PSM, gynecology and the radiology, whatever the subjects that these three subjects will be uploaded until the ban is lifted. Okay, so you can access from the Google Drive only. Okay, so those who are new to this channel, please do subscribe and share with your friends, and also don't forget to like. Guys, if you like this video, it will be reaching the more students, and the more students will be benefiting from this video. So let's start the session, guys. We will be discussing now. And so this is Dr. Krishna Menon. So this is Dr. Krishna Menon, and he is one of the most prominent obstetrics and the gynecologist from the 1950s, and he has done one of the most uh, efficient efforts to strengthen the obstetrics case, because imagine in the last 90s until the 90s or the 80s, we still have the only the home-based delivery, right? Still some of the villages also having the home-based deliveries only. It can lead to the septic shock, and it can lead to the infections to the mother, and also neonatal mortality and maternal mortality. But the Dr. K Menon has done his best to aware the people that the institutional deliveries is important, and to avoid these infections and the mortality rate, he has done so many efforts to strengthen this obstetrics care. And one of his contributions is he has find out the what are the causes is happening for the hypertension patients, and also he has done the how to prevent the eclampsia with the different types of the drugs regimens, and also how to control the diabetes. He has done many contributions, and over the time his contributions was excelled from the Cambridge University, Harvard University also. So one of the inspirations for our generation. So let's start the discussion, guys, without the delay. So today we will be discussing the gynecology, right? So gynecology is a very vast topic, so still we will be discussing from the basics itself. So when I say gynecology as a basics topics, what is the most important, guys? Anatomy, right? So the anatomy part is very important. So first and foremost is what is the anteversion and what is the anteflexion. Okay, so anteversion means it is a relation, it is going to look at the anterior side only. Okay, in the anterior of the pelvis, the most of the pelvis organs should be in the anterior looking. If it is looking the back side like posterior or the retroverted, that is an abnormality. So we are having the anteversion and the anteflexion. So anteversion, this anteversion is at the location of the vagina and cervix. Okay, this angle is at the vagina and the cervix. And anteflexion, this is the at the uterus and the cervix, and the number is important. Anteversion is 90 degrees and anteflexion is 120 degrees. So we also have the retroversion. Retroversion is most commonly seen with the endometriosis. Retroversion is most commonly seen with the endometriosis. Some of the other conditions like adenomyosis or the fibroid or the any Mullerian agency is also seen, but the most common is endometriosis. This is the one point that you have to remember. And coming to the ligaments, whenever the uterus is present, uterus needs the ligaments. What are the ligaments that is important? For example, just now we said what is the anteversion, right? It is between the vagina and the cervix. What is important to maintain this? That is a round ligament. That is the round ligament. And we should not maintain the retroversion, so we have to prevent the retroversion. So to prevent the retroversion, what is the ligament that is important here? That is uterosacral ligament. Okay, backside what we have? Sacrum. So this uterosacral is maintaining that prevention of the retroverted ligament. And next, coming to the other one, there is a triradiate ligaments. They are triradiate ligament. So what are these triradiate ligaments? These ligaments are very important. Okay, so how can you remember this? Remember with the mnemonic of cup. So cup, this is the cardinal ligament, this is the cardinal ligament, and next one is the uterosacral ligament, and the last one is the pubocervical ligament. So if you observe, I have discussed all the ligaments. One ligament that I have not discussed, that is the broad ligament. So broad ligament is not important for the uterus structures. Surrounding structure, it is present, but for the support, for the anteversion, to prevent the retroversion, the broad ligament is not going to support the uterus. That is the one point that you have to remember from the basics of this thing. Next, coming to the arterial supply. So we have the arterial supply, especially there is a anterior internal iliac artery. So this is the anterior iliac artery branch that is going to give rise to the uterine artery. That is going to give rise to the uterine artery, and uterine artery has to go through all the layers towards the myometrium, right? Until the endometrium we have to reach that. How we are going to reach? So remember the mnemonic: you are all really bad singers. Okay, you're all really bad singers. U for uterine artery, A for arcuate artery, this is the arcuate artery, and R for radial artery, and B for basilar artery, and S for spiral artery. Okay, so this is how the uterine flow will be continuous till the inside of the layer. Next, there is a other artery, that is the Samson artery. So where does this Samson artery is present? So Samson artery is important for the round ligament. And next, ovarian artery. Ovarian artery is also branch of uterine artery. It is also branch of uterine artery. Okay, next coming to the cervix also we have the artery, right? So the cervix, which will be important to maintain the arterial supply. So the cervix will be having the arterial supply from the branch of the uterine only, so it is going to give rise to the ovarian, and also it is going to give rise to the cervix. So this is known as a descending cervix artery. Okay, descending cervical artery. Next, coming to the nerve supply. Coming to the nerve supply, in the nerve supply it is especially T10 to L1. Okay, T10 to L1. And also another thing that you have to remember, there is a problem with the relation of the ureter. Okay, ureter towards the uterus. So why it is a problem? Because ureter have the relationship, it can damage sometimes during the hysterectomy surgery. Okay, hysterectomy surgery. Why? Because for example, this is the uterus, right? This is the uterus. So the ureter will be passing like this. Ureter will be passing like this. So when we are damaging, especially this is the internal os, right? This is the internal os. From here 2 centimeters there is this ureter. So during the hysterectomy we have to remove all this structure, right? So there is a high chance it can be damaged. So towards the 2 centimeters of the internal os there is a water under bridge. So this, especially here we have the ureter and also uterine artery. So there is a potential damage to the ureter also, potential damage to the uterine artery also. That is the one thing that you have to remember, and most commonly associated with the radical hysterectomy. This is most commonly associated with the radical hysterectomy, right? Next, coming back to the important points that you have to take note of, the threatened different types of the abortions that we present here. Okay, let's understand what is mean by the abortion. Basic definition. So abortion in India, we will be calling this if the patient is presented less than 20 weeks of age of gestation and the baby weight or the fetus weight is less than 500 grams only. So this is a definition for the abortion. This is how the most commonly the patients will be presented. And what is the most common cause? The most common cause overall, if you have to choose, it is the chromosomal abnormalities. It is the chromosomal abnormalities. And if there is not given the chromosomal abnormalities, then better choose the aneuploidies. It is the aneuploidy. Aneuploidy is also not given. Then choose the trisomy. Then choose the trisomy. Any trisomy you can choose. And trisomy is also not given. Then choose the monosomy. Then choose the monosomy X. Monosomy X is also not given. Then choose the trisomy 16. Trisomy 16. Okay, this is how we are going to differentiate the different types of the causes. All right. So what we discussed, this is for the first trimester. Okay, this is the first trimester. First trimester causes we discussed, right? Next, coming to the second trimester. What are the causes for the second trimester? In the second trimester, the most common is the endocrinopathy. Any endocrinopathy it could be. That is the endocrinopathy, hypothyroidism, PCOS, or any estrogen problems, progesterone problems that can cause. And followed by the there is a single cause. If they asking the single cause, then choose the APLA syndrome. If they asking the second trimester losses, then that will be the cervical insufficiency. So these are the causes of the abortions. How can we differentiate these types of the abortions? So for the abortion that is associated with the threatened abortion means it is just a triggering. Okay, it is telling the sign, if you don't act now, so there is a chance you can lose the fetus. So this is a reversible injury, and it is like a warning to the patient. So the findings of this patient will be bleeding, or we can say there is a spotting. Okay, spotting will be seen first trimester, and os on the examination it will be closed. Os will be closed in this patient, and uterus size is equal to the age of gestation. Period of the gestation is equal, right? Next, coming to the inevitable condition. Inevitable condition, that is already is a chance that is going to be irreversible. So whatever you act now, it is no issues that the already is happened. So this is what irreversible condition. And here also you are going to see the bleeding will be seen in this patient, and os is open here, and the uterus size is going to decrease from the period of gestation. Next one, incomplete is also bleeding will be seen. Okay, along with that there will be some of the clots will be seen, or the fetal tissues will be seen in this patient. Os is open, uterus size is decreased from the period of gestation. Okay, and also coming to the complete, here there is no bleeding. Okay, there is no bleeding, and os is closed. For this patient, os is closed, and when you check the period of gestation, it is not even present. Okay, it is not present. Uterus is like a pelvic organ only, you can't see that also. Next, missed abortion, mostly the patient even doesn't know that she is pregnant also sometimes. So there is no bleeding. Okay, no os, only the symptom the patient will be mentioning of amenorrhea will be the patient is mentioning. So how we are going to treat all these condition? For the patients threatened, as we said, this is the condition the patient is having the reversible condition, so we can still try to save the pregnancy. So how can we try? We can give the progesterone is a good hormone that can keep the pregnancy alive. So progesterone can be given, and absolute rest has to be given for the patient. And for the patients of the inevitable, this is already done. So what we can do, we can go for the medical abortion. Okay, medical abortion or MTP, you can proceed. And for the patients of the incomplete, it is itself incomplete, we have to make it complete. So suction and evacuation has to be done for this patient. And the treatment for the complete abortion, this is just a supportive treatment. If the patient is having the continuous bleeding, you can stop. If the patient is not having the bleeding, just take the rest and avoid to see if there is a patient is having the fever or any other complications. And for the patients of the missed abortion, how can you diagnose? You doesn't even know that the patient is having which type of the pregnancy. So that's why here we have to proceed for the, before we proceed for the treatment, we have to look after for the diagnosis. In the diagnosis, ultrasound. Okay, ultrasound, on that if you see CRL, the crown lump length, if it is more than 7 mm, or the mean sac diameter which is more than 25 mm, if any, or okay, this is not just one, if any one is present, and the fetal heart rate is absent, then we have to consider this as a missed abortion, and here treatment will be MTP for the patient. Okay, MTP for this patient. So this is how we are going to proceed for the different types of the pregnancy associations of these patients. Next, coming to the cervical insufficiency. Okay, cervical insufficiency, what we just said, cervical insufficiency is the, for example, you have the patients. Okay, the patient is having the second trimester. Okay, more than 20 weeks, the patient is having the recurrent types of the pregnancy losses, and more than 3, at least more than 3, more than 20 weeks, if you see this patient is having. So this is the diagnosis for the cervical insufficiency clinically. And if you observe the patient on the ultrasound, best investigation of the choice is the TVS. Okay, transvaginal sonogram has to be done for this patient. So patients who are normal pregnancy, what they have, 4 centimeters of the cervical length will be seen. So for these patients, for the diagnosis, there will be having less than 2.5 centimeters, less than 2.5 centimeters, and also there is a decreased cervical length, and along with that, the patient will be having the U-shaped cervix. U-shaped cervix will be seen in these patients. And how you are going to treat these patients? For example, if the patient is having the less than 2.5 centimeters, and also patient is having the loss, okay, and what you can do for this patient is the cervical serrage, and the most common is the McDonald's approach for this patient. In the McDonald approach, we will be using this, like, okay, this is like a purse link operation that we are going to perform in this patients, okay. And if the patient is having more than 2.5 centimeters, which is nearby the 2.5 centimeters, and no history, no previous history, then we can go for the progesterone. And also here also we have to give the progesterone. Okay, here also we have to give the progesterone. And less than 2.5 centimeters plus no history, no previous history, still we can give the progesterone, because the must be this patient is primary. So in the primary patients, surgery is not mandatory to go. If there is no history, we can simply go for the progesterone itself. So this is how we are going to follow for these patients of the trimesters. Next, moving on to the another important topic that you have to remember. So that condition is the MTP, okay, medical termination procedure. And recently the medical termination procedure, this has been given by the government of India in the new amendment 2022. Okay, 2022 amendment 1971, that is the first amendment, and it was completely changed with the some guidelines that is has been issued for the 2022. So in the 2022, the major update that up to 24 weeks we can go for the abortion. Okay, we can go for the abortion for this patient, especially if there is a social causes, if there is any social causes, or if there any eugenic clauses. Okay, eugenic causes, we can go for the patient 24 weeks. But if it is 20 weeks only allowed, if there is a contraception, okay, if there is any contraception usage, we have to go for the 20 weeks only. We should not be go for the 20 allowed the patients. And how many doctors, how we are going to do? So for the 20 weeks we can need only one doctor opinion. If it is less than 24 weeks, we have to approach for the two doctors opinion. Okay, two doctors opinion has to be done for this patient. But in severe cases, for example rape case, or the patient is having any other condition anomaly, the maternal physical health is deteriorating, or the baby is having this too much anomalies, then we have to go for the board. And this board which will be having the radiologist, so the specialist for the fetal sonography, and along with that obstetrics gynecologist will be presented, and also pediatrician. Okay, and also pediatrician. And sometimes RMP, the registered medical practitioner from the other hospital, not from the same hospital, will be also consisting. This board has to approve whether this patient is need the more than 24 weeks has to be done or not. And next, who has to perform this surgery? Who has to perform? So if ever the patient is obstetrics gynecologist patient, sorry, if ever the doctor is the obstetrics gynecologist by himself or the herself, or the patient has done the diploma in that course, or the patient or the doctor is the registered medical practitioner. Okay, registered medical practitioner. But this registered medical practitioner, at least he has to perform the 5 MTPs by himself. He has to perform 5 MTPs by himself, or the 10 MTPs he has assisted. Okay, and 25 MTPs he has assisted. Must and should, he has to be assisted for the 25 MTPs. Okay, this has to be done by the RMP before they proceed to this surgery. Next, coming to the consent. So consent, if it is less than 18 years, or the patient is mentally retarded, okay, then we have to go for the guardian or parent. If she is more than 18 years, no other consent is needed. Herself can give. No other consent means not even a spouse. Spouse is not needed. Same as the parents or the guardians is not needed. So herself can give the consent. That is the one thing. Physical examination. Can she refuse? So physical examination, if she is a rape victim, she can refuse. Okay, she can refuse. That is the one point that you have to remember. Next, coming to the another important point. Recently in the INICT has been asked, is the DNA sample has to be taken or not? So DNA has to be taken of the fetus. So the fetal tissue has to be saved for the patient. Whatever the guidelines tell how to record, at least 3 years records has to be saved, and if there is a notification less than 72 hours, there should be issuing the notification. Transparency has to be maintained and should not be disclose the patient details. Okay, disclose is contraindicated and should be avoided. That has to be followed for the protocol. So this is the overall important points of the MTP and how we are going to proceed for the MTP. So less than 9 weeks, less than 9 weeks, the best approach is the medical abortion. The best is the medical abortion. So how we are going to proceed for the medical abortion? We are going to give the two drugs, mifepristone, this is a progesterone antagonist, and also misoprostol. Okay, this is the drug of the prostaglandin. So mifepristone, the drug that we are going to give for this patient, how much is the dosage? So this is given on the day 1. So mifepristone is given on the day 1. So the dosage of is only one tablet which will be consisting of the 200 mg. Okay, and after that on the day 3 the misoprostol is given, and misoprostol is consisting of the 4 tablets. Misoprostol is consisting of the 4 tablets, and here it is 200 micrograms. 200 micrograms that is given, and it can be given per vaginal, it can be given the sublingual, it can be given the per oral also. So this is how the mifepristone and the misoprostol is given for this patient. And on the day 15, on the day 15 you have to check up. Okay, follow-up has to be done for this patient. So this is the protocol for the less than 9 weeks of the patient. All right, next approach is for the patients who is more than 9 weeks, more than 9 weeks, and if they are more than 12 weeks, the best is suction evacuation. Suction evacuation has to be done for this patient. And suction evacuation is done how? So this is, you can see, this is known as a Karman's cannula. This is known as a Karman's cannula, and this cannula is equal to the uterus size. This is equal to the uterus size only. Okay, so we are going to use the Karman's cannula. And what is the pressure? Karman's cannula as a surgery, and it has the size equal to uterus, period of gestation, and then the pressure it is used by it is 600 mmHg. 600 mmHg of the surgery it is used. Okay, and next we also have the manual vacuum aspiration. Manual vacuum aspiration. Why this manual vacuum aspiration? If there is no current, or the village areas, we can go for the manual vacuum aspiration. And here we will be using of the MBA syringe. MBA syringe. It has the two types, one pinch valve, two pinch valve. Nowadays we are using the two pinch valve only because the one pinch valve is obsolete now. So we are using the two pinch valve. Two pinch valve. How much it can carry? It can carry 60 ml. And how much is the pressure? 660. Okay, 640 to 60, 640 to 660 mmHg pressure has been used for the evacuation, right? So these are the 2 points that you have to remember. So first is a suction and evacuation. Yes, suction and evacuation, and manual vacuum aspiration. So there is a question that is asked: if the patient is underwent the abortion. Unfortunately, the Karman cannula is invaded into the uterus. It is invaded into the uterus. What has to be done for this patient? Do not remove immediately. Okay, do not remove. Keep it same place and shift to the OT. Shift to the OT and go for the laparotomy. Go for the laparotomy or laparoscopy. Okay, best is a laparotomy we can go, and from there we have to remove because it can cause the bleeding, so that's why it should not be removed in the immediately. We have to shift to the OT and do the patient surgery. Right, this is the overview of the basic things that you have to remember about the MTP. Okay, MTP question can be asked anytime, guys, so please do revise this important topic. Right, next, moving on to the ectopic pregnancy. So we are actually, if you can observe this image, so the pregnancy has to be here or the pregnancy has to be here, but unfortunately it is happening at multiple spots, but it is not in the patient uterus. So this condition is known as a ectopic pregnancy. This condition is known as a ectopic pregnancy. Right, so in the patients of the ectopic pregnancy, how these patients will be having this condition? Usually this is a risk factor. There will be a important risk factor that the patient will be having, that is the salpingitis. Okay, salpingitis. So this is the infection, pelvic inflammatory disease can cause, and also previous history. Okay, previous history also will be contributing to the patients. And one thing that you have to remember here is the OCPs will decrease the chance, of the ectopic. Like absolute decrease of the chance will be seen with the ectopic pregnancies of those who are using the OCPs. That is the best thing. Right, next, how the patient will be presented. So the patient symptoms is common amenorrhea. Amenorrhea will be seen in this patient. Amenorrhea with bleeding, okay, which is doesn't look like they are bleeding for the menstrual cycle. Okay, and also there is a abdominal pain. This is a triad, and along with the triad the patient will be having the radiating pain and decreased BP, increased heart rate, and guarding abdominal pain if ever these present. So these are the signs of rupture pregnancy. These are the important points and the diseases that you have to remember in this condition. These are the signs. Those who are new to this channel, please do subscribe. Okay, so these are the stable patient. This is the unstable patient. We have to immediately move for the surgery options. And you can see what is the most common type. So the most common type is the tubal pregnancy. And in the tubal pregnancy, ampulla is the most common sign. On the ultrasound, you are going to see the tubal ring sign and also Bagel sign. You are going to observe on the TVS. Right? Next, the other type, this is a non-tubal type. This is the non-tubal type. This is the non-tubal most common. If the tubal most common, that is the ampulla. Tubal most common is overall. Non-tubal is the ovarian. And there is a criteria for the ovarian. That criteria is the Spielberg criteria. And very rare, that is seen with the C-section scar. Next, cervical is also very rare, and cervical is having the specific criteria, that is the Parman criteria. This is the Parman criteria. And abdominal pregnancy, it is having the Studi-Form criteria. And the most important thing is that the abdominal pregnancy is having the high survival rate. Some patients are even born with the abdominal survival of the ectopic. Okay, and most dangerous, or we can say the most longest ectopic is interstitial. Why interstitial? If you can observe, this is the patient will be having the cilia and the tubal, right? So until here there is a myometrium. So this myometrium can feed this fetus. So that's why, so this is the long, and almost it can take up to more than 10 weeks also. More than 10 weeks of the survival which will be seen. because remaining all will be less than 6 weeks, 8 weeks, that will be seen. But it can have the long survival rate, but eventually it will be deteriorated. But if there is a birth will happen, then it is a abdominal ectopic. Abdominal ectopic can have the, can give birth also. That is what we see in some patients. All right. So next, moving on to the other important points. So physical examination. In the physical examination, per vaginal examination, there is a bleeding. Okay, per vaginal examination, bleeding will be seen, and the uterus size is not equal to the period of gestation. It will be decreased, and the cervical tenderness will be seen. Cervical motion tenderness will be also seen in this patient. So if the patient is stable, if the patient is stable, no signs of rupture, no signs of the rupture, and also patient is willing to go for the therapy. So what we can do for this patient, we can go for the salpingectomy. We can go for the salpingectomy for this patient. Okay, sorry, so we are only talking about the medical therapy. So for the patient of the medical therapy, if it is a stable, no signs of the rupture, then go for the TVS. Ultrasound has to be done and confirm that is a ectopic pregnancy. Confirm it is a ectopic pregnancy. How can you confirm? There is no gestational sac in the uterus, so gestational sac is in the tube. That is the confirmation for the ectopic pregnancy. Then allow for the beta HCG levels. Allow for the beta HCG levels. And the criteria for the TVS, it is 2000 international units. And abdomen, it is 6000 international units. And if you see, it is 2000 international units, less than 2000 international units. So mother is still stable after 48 hours. Okay, after 24 hours. If it is raised by 33%, okay, this is a slow raise. So for this patient, we can go for the methotrexate. Methotrexate has to be given for this patient as a therapy. Okay, 1 gram, 1 dose, 1 gram, 1 dose intramuscular route can be given for this patient. Okay, so 1 gram per kg, 1 gram per kg. Only 1 dose is fine for this patient. But unfortunately, the patient is not stable. The patient is unstable, or medical therapy is not, medical therapy is not suitable. That means no work has been done from the methotrexate, and the patient is having the severe shock. Patient is having the severe shock, and for these patients, we have to go for the surgical approach. Surgical approach. And what is the surgery that is most commonly done? Salpingectomy. Okay, salpingectomy has to be done. Remove the tube, that has to be done. Never you remove the ovaries. Okay, only salpingectomy has to be done. If there is a ovary ectopic, then you have to remove the ovaries, but here we are not going to remove the ovaries. This is the surgical approach that we are going to do. Okay, and if it is open, we have to do the open laparotomy if there is a signs of peritonitis. If there is a signs of peritonitis. But if there is no signs of the peritonitis, if the patient is flexible or the patient is having the normal vitals, then we can proceed for the laparoscopy approach. So this is how we are going to treat the patient from the stable and the unstable of the patients of the ectopic pregnancy. Right? Next condition. So next condition we are going to discuss is the Highyield form mole. Okay. So this patient is suffering from the partial mole, and here this patient is the complete mole. Complete mole. So what is the difference from the partial mole and the Highyield form of the mole? So this is a gestational trophoblastic disease. So the patient is suffering from the gestational trophoblastic disease. So the trophoblast is going to proliferate instead of forming the fetus. Okay. So how this patient is caused this condition? So there is a ovum. Okay, ovum has to be fertilized, right? So ovum is going to fertilized by the sperm. Okay, but here they are two sperms. They are two sperms that is going to have this two sperms is going to attack this. And if you see, this is the end, This is the N, and here it is the N, right? 23, 23, 23. So this baby can form the triploid. So triploids or the aneuploids, they can't survive in the uterus. So it will be 69XXX. It is not going to survive. 69XXY. It is not going to survive either. Okay. So that's why this babies cannot survive. So maternal genes is present in the partial mole. So is the sperm, so is the ovum is present. So fetal tissue of the partial mole is present. Fetal tissue is present in this patients, and there is specially KIP57 gene is specifically from the maternal. This is also present in the patients of the partial mole. On the ultrasound, you can visibly see the fetus. Okay, fetus is present. How can we see? So there is a circulation. You can see there is a circulation, and less trophoblastic is seen in this patient. Okay, so for example, this is the placenta. That placenta is receiving this blood. That is what look in the Doppler of this ultrasound. A fetal tissue is present, and also proliferation of the trophoblast is present in this patient. So the best diagnosis is the histopathology. Okay, biopsy is the best investigation of the choice for this patient. Okay, and coming to the treatment is suction and evacuation. Suction and evacuation has to be done, but using the sharp curate has to be used for these patients. Next, complete mole. So complete mole patients is different from the partial mole. And why there is no fetal tissue here? Let's see. Again, there is a ovum has to be formed, and sperm, and here also sperm, right? Most commonly only it is a monospermic condition. It is a monospermic condition. So rarely it can be dispermic. But this ovum is empty. This ovum is empty. So there is no number of chromosomes here. Only that is present here is the one sperm. So this patient is consisting of the one sperm and the two sperms only. Okay. So it is going to form the diploid. Okay. Two sperms only. That is 46XY. That is going to present in this patient. Okay. And maternal genes is absent. So KIP57 is also negative in this patient. On the ultrasound, you are going to see snowstorm appearances. On the ultrasound, you can look that there is a snowstorm appearances. There is no circulation. There is no differentiating between the placenta and the uterus. Deciduous differentiation is not seen in this patient. And also no fetus is present in the ultrasound. Again, the best is histopathology has to be done for this patient. And here also suction and evacuation. Here also we are going to proceed for the suction and evacuation for this patient. So this is what the main difference from the patients who is suffering from the partial mole and the complete mole. Another important points of the partial mole and the complete mole. So the most common is the complete mole, guys. In the both, the most common is the complete mole. So how can you differentiate how the patient is presented? So generally, the most commonly the patient will be presenting with the amenorrhea. Patient is presenting with the amenorrhea, and period of gestation with uterus size will be increased because of the trophoblast proliferation. That is also seen. It does look like a 12 weeks of the pregnancy at the 6 weeks of the pregnancy only. So that is going to present it. And along with that, there is a bleeding, spotting will be seen, plus tissue is coming from the vaginal. Okay, per vaginal examination, you are going to see the tissue like grape like vesicles that will be seen in this patients. That is also seen in this patients. Okay, so and also there is a adnexal mass, and this adnexal mass is theca lutein cyst. These are the theca lutein cyst. It is a benign cyst, and for this patient there is no treatment. We are not going to remove the oophorectomy. And reassurance, after removal of this proliferation via suction and evacuation, theca lutein cyst will be decreasing in this patient. Okay, theca lutein cyst is decreasing, and after the suction and evacuation, you have to follow up with the HCG levels. Okay, first we are going to follow up for the weekly until four samples is coming normal. Until then, we have to follow up for the weekly only. If 4 samples is normal, then we have to go for the monthly, one for monthly until 6 months. And after this, pregnancy is contraindicated. Is it the lifetime pregnancy contraindication? No. At least the patient should have 6 months contraindication from the pregnancy. But we can't tell the patient that has to be stopped. So what we can do? So we can tell the patient to take the OCPs as a remedy for the birth control until 6 months. Okay. So 6 months OCP has to be used for these patients. So this is how we are going to treat for the patients of the partial mole and the complete mole. Okay, direct question can be also asked in the examination. Next, we are having the gestational trophoblastic disease. Gestational trophoblastic disease can become the gestational trophoblastic neoplasia. It can progress to the carcinoma. So one among the carcinoma, that is the choriocarcinoma. That is the choriocarcinoma patients. So this choriocarcinoma, which will be associated if the patient is full term. Post full term, it can progress to the choriocarcinoma. Or patient is having the molar pregnancy. So patient is having the molar pregnancy history, and the second pregnancy can also progress to the choriocarcinoma risk. That is also seen in this patient. So how we are going to treat these patients? Okay, usually this is aged females more than 40 to 50s. Okay, and the presentation will be bleeding per vagina. On you have to go for the staging of this patient. Stage 1 is uterus is involved. Stage 2, vagina is involved. Stage 3, metastasis, especially lungs. Stage 4, again metastasis, even more progressive to liver and the brain. Okay, to liver and the brain for this patient. So there is a criteria: low risk and the high risk. So if you see the patient with the low risk, one drug is enough, that is a methotrexate. One drug is enough, that is a methotrexate. If it is a high risk, we are going to follow the Boxha regimen. Okay, Boxha regimen. And this Boxha regimen contains of the 5 drugs EMACO. Okay, EMACO drugs. You can just remember etosimide, methotrexate, acetyl drug, and also cyclophosphamide, and also some other drug that will be used for this patient that starts with the O. So just remember EMACO. You can even recognize from the options itself. These are the patient treated how for the patients of the choriocarcinoma. Next, moving on to the most important part of the gynecology, that is the infections, that we are going to discuss now about the infections. First one, this is the genital TB. Okay, genital TB in the patients. So genital TB is not a primary cause. For example, the patient is suffered from the lungs. Through the hematogenous route, this patient is developed the genital TB. So this is a secondary cause. The most common cause is the secondary cause through the hematogenous spread, and it will involve most commonly tube. Fallopian tube is involved. In the fallopian tube, it is the ampulla. It is the ampulla that is involved in the patients. And how the patient is presented? The patient is presented with the amenorrhea. Okay, amenorrhea. In the early, when the patient is doesn't even notice, she is having the dysmenorrhea. But the dysmenorrhea, most of the patients will not come to the OPD simply for the dysmenorrhea. So they will be presenting with the amenorrhea. But early symptom is dysmenorrhea. And also fertility issues. Fertility issues will be also seen. So there is no conceiving of the child for at least 6 months or the 7 months with amenorrhea. So the patient might be having this problem. And also other symptoms, constitutional symptoms, fever, weight loss, night sweats, all this will be seen in this patient. Okay, so this is seen in the virgin females most commonly, who has had the recent marriage. They will be presenting with this fertility issues. So but she is suffering from before the marriage itself. That is also differentiating factor that you have to understand. And the investigation of the choice, you have to go for the biopsy. Biopsy has to be done for this patient at the time of the premenstrual stage. Even though she is a amenorrhea patient, you have to take note about her cycle, and the premenstrual time you have to get this biopsy. Okay, and You can go for the other diagnostics, and this other diagnostics is hysterosalpingography and ultrasound. Ultrasound can be done for this patient. And coming to the treatment is anti-tubercular therapy. Anti-tubercular therapy is done for this patient. But if it is a complicated because of the fertility, the treatment for the fertility is most of the times it is a irreversible damage case. So we will be recommending for the patients of the IVF has to be done for this patient. Okay. Next, let's see what are the things that you will observe here. So there is a block here, right? So this is known like a Gulf hawk stick, Gulf stick appearances, Gulf stick appearances, and this is like a beaded appearances. This is beaded appearances. Okay, so this picture is hysterosalpingography. We will be infusing of the saline into this patient, right? This is the hysterosalpingography, and this is how the tubal block will be seen in this patient. Tubal block will be seen. So this is how we are going to diagnose the patients of the genital TB. Next, from the picture itself, you have to understand what is this condition. Patient is having the inflammation of the endometrium, fallopian tube, and also ovaries, okay, and also vagina. All these are involved in one patient. What is this condition? So this condition is known as a pelvic inflammatory disease. So this is the pelvic inflammatory disease, and most common risk factor for this patient is the multiple partners. This is the risk factor for the patients of the multiple partners. And the most common organism of the patient is chlamydia. Chlamydia is the most common cause. In acute stages, gonorrhea. Gonorrhea is the acute stages. Those who are using the IUCD, the copper agents, this is the actinomyces, and those who are in the more than 45 years. This is the E. coli, old individuals, E. coli, and the young individuals we already just now discussed it, right? So that is seen with the patients of the TB. That is seen in the patients of the TB condition. And how these patients will be presented. So the patient presentation, will be symptoms involves the abdominal pain, okay, and also adnexal pain. Adnexal pain is also seen in this patient, okay, and fever, and also menstrual issues. The patient is also having the menstrual issues. That is also one of the patient finding. And sometimes there is a vaginal discharge. Vaginal discharge will be associated with which condition, guys? Gonorrhea, okay, non-urethral. All these conditions can be seen in this patient, right? That is also commonly seen. And along with that, on the examination, physical examination, cervical tenderness. So we hear cervical tenderness in only two conditions. One is ectopic and other one is the PID patients. Okay, only these two places we are going to hear. Cervical pain will be seen on the examination, and adnexa mass. You will be feeling this adnexa mass with pain. Will be seen in this patient, and erythrocyte sedimentation rate will be increased, CRP is increased, WBC leukocytosis will be seen in this patient, and if it is a chlamydia, nuclear test is positive for this patient. All this will be seen, and if you trace the discharge with the culture will be also showing the sensitivity of this patient. Okay, and initial investigation, initial diagnostic test for this patient is ultrasound because of the mass that we are going to see, okay, but the best investigation of the choice, the best investigation of the choice for this patient is the laparoscopy. A laparoscopy has to be done for this patient. That is how we are going to see. And the treatment for the patient of the chlamydia, azithromycin, right, azithromycin is treated for this patient. For the patient of the gonorrhea, it is going to be the ceftriaxone given is for this patient. And should the partner has to be treated for this patients? Yes, partner also has to be treated for this condition. So this is how the PID patients will be presented, guys. Next, another thing that you have to remember that generally the vagina is acidic. So it is acidic due to what? This is acidic due to lactobacillus. This is due to lactobacillus, and these lactobacillus which will be maintaining of this acidic condition, because it is going to convert the glycogen. It is going to convert the glycogen into lactic acid. pH is very important. Sometimes exam is also asked in this questions. If it is less than 4.5, what is the infection? Candida. It's still resistant to the acidic. If it is more than 4.5, this is the alkaline. Here you can have the vaginosis and also trichomonas infection. Trichomonas or the bacterial infection. Generally in the females who is reproductive age, normal in the reproductive age, it will be around 4 to 4.5. This is normal. Pregnancy, it is less than 4.5. Menopause patients, it will be 6 to 8. It will be 6 to 8. Okay, that will be seen in this patients. And next, moving on to the menstrual cycle. So menstrual cycle questions can be also asked. Just remember what are the important points of this menstrual cycle. Not has to be noted entire, but at least you have to take note of the basics, right? Basics is very important, guys. So let's see. There are the two phases, right? There are two phases. One is the follicular phase, okay, which is also known as a proliferative phase. This is the proliferative phase, right? Other one is the luteal phase, also secretory phase. Secretory phase of the patient. Here you can see. So this is the follicular phase. In the follicular phase, there is a growth of the ovary. In the luteal phase, there is a growth of the uterus. So this is the differentiating between the follicular phase and the luteal phase. And what are the hormones that is involved in the follicular phase and the luteal phase? In the follicular phase, as I said, this is about ovulation. This is about the ovulation. And if the ovulation has to be done, follicle stimulating hormone is the one which will be triggering this factor. And the most predominant is the estrogen. The most predominant is the estrogen in these patients. And this estrogen will be acting on the two types. One cell is the granulosa cells, and these granulosa cell which will be producing of the further estrogen. Okay, this is the E2 type, and the other one is the inhibin. This will be inhibin B. Why this inhibin? Inhibin means inhibiting. Once they reach the normal, this inhibin will stop the FSH and the LH. So this will be stopping the FSH and LH. Okay, when they reach the normal. Next, we also have the theca cells. Okay, here we also have the theca cells. These theca cell will produce the androgens. Okay, these theca cells will be producing the androgens, and more the androgens, more there will be estrogen for the production. And ovulation, how the ovulation is going to happen? Ovulation is due to LH surge. Ovulation is due to LH surge. How much is the parameter? 200 picograms level of the LH surge is happened. Exactly at what time? More than 48 hours before the ovulation. More than 48 hours before the ovulation. Is it the only LH is producing here? No. LH plus estrogen plus progesterone. LH is high, but the estrogen progesterone is also present in this phase, right? Next, coming to the luteal phase and the secretory phase, and here it is the progesterone, and progesterone will be waiting for the pregnancy to happen. If there is a fertilization, it has to maintain the uterus. Okay, and if pregnancy continues, it will be converting of the beta HCG. It will be converting to the beta HCG. Beta HCG consists of the alpha and the beta, but the beta is most important part of the beta HCG. Okay, and so it will be consisting of the corpus luteum. It will be consisting of the corpus luteum. Corpus luteum is also important for the pregnancy. If there is no pregnancy, it will become the corpus albicans. That means it is also going to shed, right? Next, this cycle is 14 days. It is a 14-day cycle and it is a fixed cycle. It is a fixed cycle. And these produce the intermediate cells. This produce the intermediate cells. And under the biopsy, you are going to see secretory vacuoles, and there is a thick cervical mucus, which will be present here. And here it is a thin mucus. This thin mucus which will be helping for the sperm to attain the hypermotility. And the cells that is present here is the superficial cells under the biopsy. Superficial cells, right? So this is the important points about the follicular phase and the secretory phase of the patient. Okay, next important points, another important points, there is a difference between the LH peak and the LH surge. LH peak and also LH surge. As I said, LH surge is important for the ovulation and it happens around 32 to 36 hours before the ovulation. And LH peak was also same, it is important for the ovulation. It will be happening around 10 to 12 hours. It will be happening around 10 to 12 hours before the patient is having the ovulation, right? So these are the changes that you have to remember for the patients of the, for the normal patients and for also the general menstrual cycle. So how can we differentiate this from the different kinds of the diseases? Okay, first we have to differentiate either two types. One is the primary amenorrhea. Primary amenorrhea. The primary amenorrhea patients, most likely if they are having the more than 13 years, the patient is more than 13 years and breast is not yet developed, that means the thelarchy phase is around the 9 to 10 years only, but the thelarchy is not yet attained by the patient, and also menarche is also not attained by the patient. Is this two conditions is present? Yes, this could be the primary amenorrhea more than 13 years. More than 15 years, the patient is more than 15 years, but here the breast is developed. That means ovaries are functioning properly, estrogen and progesterone is producing properly, but the menarche is absent. Menarche is absent. So likely to be the patient is having the condition with the uterus alone because hormones is working properly. So how can we differentiate for these patients? Okay, and let's see one by one. The first condition is the Turner syndrome. The first condition is the Turner syndrome. This is the monosomy X. Either the Down syndrome, Turner syndrome. One among the each will be asked in every exam, not just our national exams only. Even in the USMLE, other competitive exams also, this question is asked. Turner syndrome. So in the patients of the Turner syndrome, the effect is girl has to have the XX normally, but this patient only XO, one X is absent in this patient. So likely to be the patient uterus is present, but ovaries are streaky. That means they are not functioning properly in this patient, and there will be webbed neck, and also wide breast. The knot, it is well developed, so the development of the wide breast will be seen in this patient, and also growth hormone is decreased, so short stature is also seen in this patient. Mental retardation is not present. This patient is having the normal IQ. This patient is having the normal IQ. And overall, the most common overall for the primary amenorrhea is the Turner syndrome, guys. The most common overall is the Turner syndrome. Next condition is the Swyer syndrome. Next condition is the Swyer syndrome. So this Swyer syndrome patient is 46XY. Actually, what we said, normally the female has to have the XX, but this patient is having the XY. This patient is having the XY. And here ovaries is present for this patient, but not well developed. Not well developed. So this patient is having the high testosterone. This patient is having the high testosterone, and this is also not well concentrated. So that's why there is no Male features. She is having the ovaries but not well developed, and the patient is having the testosterone but not highly concentrated. So overall these two conditions, okay, overall these two conditions we'll discuss back again. Next condition, that is the Kalman syndrome. Next one is the Kalman syndrome. So the Kalman syndrome patient is having the hypogonads, that means not well developed gonads. This is the XX only. The patient is XX only, hypogonads, and also patient is having some of the pituitary problems. The patient is also having the pituitary problems. Hypogonads and the pituitary problems is seen in this patient. Next, we all seen overall about the gonadal issues. Now, uterus issues, that is Mullerian agenesis. This is the Mullerian agenesis. Here the uterus is absent in this patient. Uterus is absent in this patient. Okay, that means gonads is normal. Gonads is normal. If the gonads is normal, obviously the breast will be well developed due to the hormonal, right? And the one of the actresses in the Hollywood, she is having this Mullerian agenesis, and she suffered from this Mullerian agenesis. She has openly admitted also. Okay, and for these patients we are not going to do any treatment because they already uterus implantation is not possible, right? So for this patient we can go for the vaginoplasty. When they want to have the surgery, they can go for the vaginoplasty. At their attainment of the sexual maturity, they can go for that surgery. Okay, next, another condition is the androgen condition. We also have the androgen sensitivity condition. Androgen sensitivity condition, and here androgen sensitivity condition, it is again XY. Here XX is the normal, but this patient is also XY. This is also one of the condition, but the differentiating feature of all this condition is one feature from the androgen sensitivity is they have the axillary hair. Axillary hair, this feature is important feature that you have to understand in the examination. Okay, this is a testicular condition, but still the patient is having the axillary hair. And here also uterus is absent. Uterus is absent, axillary hair is present due to androgens. Uterus is absent but the breast is present due to estrogen, from the gonads. That is the features that you have to remember and differentiate these conditions, guys. Next, how can we understand this condition? All this condition, what is telling us? All these conditions have telling us these are belongs to the different types of the conditions. For example, Turner syndrome and also the Swyer syndrome, both are these conditions. The Turner and the Swyer syndrome conditions are hyper, this is the hypergonadotrophic, hypergonadotrophic hypogonadism. So the problem is in the gonads, right? So the patient is having the less estrogen, less progesterone, but high FSH and the high LH. Next, coming to the Kalman syndrome. This patient is having problem both the gonads, both the pituitary. So this is hypopituitarism and also hypogonadism, right? So FSH, LH is decreased, so as the estrogen and the progesterone is decreased in these patients. Okay, next, Mullerian agenesis patients. In the patients of the Mullerian agenesis, the gonads is normal, so estrogen, progesterone, FSH and the LH, everything is normal, but the problem is uterus is not present here. Uterus is not present. Androgen sensitivity syndrome. Androgen sensitivity syndrome, estrogen and the progesterone is not present. Instead of that, there will be presence of the testosterone. Testosterone is raised in this patient because of high activity of the androgens. Androgen testosterone is going to convert back the androgens. Androgens convert back to the testosterone in this patient. So this is the features that you have to remember, right? These are the causes. Next, last one. This is also going to cause the patient with the cryptomenorrhea. What is mean by the cryptomenorrhea? Cryptomenorrhea means there is a menstruation but in the closed chamber. So the patient is having uterus normal, the patient ovaries is normal, patient is having the XX, that is also normal in this patient. Then what is the problem in this patient? So the patient either is having the imperforate hymen, the patient having the imperforate hymen, one of the cause, imperforate hymen, the hymen is completely closed, or transvaginal septum, transvaginal septum is present in this patient. So these are the two conditions that will be associated with the cryptomenorrhea, right? So these are the conditions that you have to differentiate, depends on the features the examiner is going to ask us. Okay, please do not make the mistakes in this condition, guys. Next, coming to the secondary amenorrhea. Secondary amenorrhea. So these patients with the secondary amenorrhea, what will be the most common cause? If you can observe, they already attained the menarche. They're having the second time of the amenorrhea. Obviously, there will be most commonly pregnancy, right? Pregnancy is the primary cause for these patients to have this. And also there are conditions like Sheehan syndrome, and also Asherman syndrome. Sheehan syndrome, and the Asherman syndrome, and the tumors, pituitary tumors, or PCOD patients, that is also seen. All these features will be seen in the patients of this condition. And how can we differentiate whether the patient is suffering from the uh, primary secondary amenorrhea? How we are going to differentiate? So in the patients of the secondary amenorrhea, we have to look after for the different types of the levels. Okay, the levels that you have to look for this patient. For example, let's take Sheehan syndrome patients. So Sheehan syndrome patients, hormonal levels. Sheehan syndrome means what happening here? There is a pituitary necrosis due to the PPH, postpartum hemorrhage. There is a pituitary necrosis. So this patient lab values will be, everything is decreased, pituitary itself gone. So FSH and the LH is decreased, so as the estrogen and the progesterone is decreased in this patient. Okay, Asherman syndrome. What is the cause of the Asherman syndrome, guys? Asherman syndrome is due to adhesions. Adhesions is the problem. So the problem is in the uterus only, right? This is not due to any other condition. So for this patient, everything will be normal. If you take the FSH, LH, and the estrogen and the progesterone, everything will be normal. And the tumors, related to the tumors, mostly the FSH and the LH will be increased. Prolactinoma, it is going to increase this too, and it will decrease the estrogen and the progesterone. PCOD patients, it will increase the FSH, okay, and the normal LH, sorry, it will be opposite, increased LH and normal FSH, okay, and estrogen is completely absent. That's why the patient is not having the menses. So this is how the different types of the lab values that you have to understand. This is a recent INICT question that should not be ignored, guys. Okay, next, dysmenorrhea condition. Okay, next we'll be discussing of the dysmenorrhea. So for the patients who is suffering from the dysmenorrhea, the most common is the primary, and in the primary, this is due to prostaglandins. This is due to prostaglandins. And for this patient, the treatment is simply NSAIDs has to be given. And coming to the secondary. Secondary means there should be underlying cause. There should be underlying cause. And the most common underlying cause is the endometriosis. And for the endometriosis, you have to treat the patient with the underlying causes, right? That has to be done. Next, menopause. So we have the condition menopause. This is also considered as a pathology only. It is a normal physiological process, but if it is occurred less than 45 years, this is the premenopausal, premenopausal condition. And when it is a physiological, exactly 51 years in India, exactly 51 years, it is normal, the patient is having this condition. Okay, this is the premature. This could be the pathological condition. Okay, but physiologically the patient is having the menopause. At least how many months? At least 12 months she should have the menopause patient. But the unfortunate thing is that after the physiological process of the menopause, the patient is having the problems. So this is the where the most of the conditions that we are going to see in this patient. Okay. So on the labs, you are going to see there is a decreased estrogen, decreased progesterone that will be seen in this patient, and so as FSH will be also decreased, and normal LH will be seen in this patient. Okay, almost all the hormones will be decreased. And the side effects of the menopause, I'm talking about side effects of the menopause. What are those? First and foremost, the patient is having the hot flashes because of less estrogen. This is the most common, because of less estrogen. One point. Okay, and she is having the night sweats. So night sweats can cause a disturbed sleep. Again, this is also due to decreased estrogen for the patients. Okay, and also atrophy, vaginal atrophy will be seen. Again, this is also again due to the estrogen of the patient is decreased. So for this patient, treatment is fluoxetine. Okay, fluoxetine has to be, it is an antidepressant, can be given for this patient. And not just that one condition, there are many other conditions. For example, if the patient is having the decreased cardiovascular activity, right? So the cardiovascular activity is deteriorating for the patient, and the bone conditions is deteriorating. One among them is the patient is having the uh, osteoporosis, right? And also hot flashes. Okay, hot flashes is seen. All these conditions will be associated with the risk of this condition. And for these patients, the treatment is alone, which will be helpful. That is the hormone replacement therapy. So hormone replacement therapy has to be given. So we can give the combination of estrogen and progesterone for this patient. Okay, estrogen and progesterone for this patient. So these estrogen and progesterone can helpful for the cardiovascular disease to decrease. Osteoporosis can be decreased for this patient, and also hot flashes will be also subsided. Just because she is a postmenopausal, there is a high chance cancer also. So the cancer chances also decreased in this patient. Okay, next, if you give only estrogen, it is not going to the that best. It can decrease the cardiovascular and also osteoporosis. But only estrogen can have the risk of endometrial proliferation, right? Endometrial cancer risk will be associated with this patient. Progesterone is also acting, so that's why cancer risk is decreased. Alone the estrogen can increase this risk. Okay, that is the one point that you have to remember. But contraindication, if there is a patient suffering from the breast cancer, we are not going to give this. If the patient is having the thrombosis, this is also not given because it can increase the coagulability state. Patient is having the MI, we are not going to give. Patient is having the stroke, CAD or the CVD, we are not going to give this for this patient. Liver disease and the hepatic cancer history, or patient is a migraine condition, we are not going to give. These are just like a our normal OCP contraceptives we will be discussing, right? Same like that. Next, osteoporosis. How we are going to treat the patient with the osteoporosis? Osteoporosis is the most commonly, right, due to the age post-menopausal the patient will be having. This is also due to estrogen. And bone mineral density was decreased in this patient. Bone mineral density was decreased in this patient. So the drug of the choice for this patient is the bisphosphonates. Bisphosphonates. Okay, this bisphosphonates is going to block and decrease the osteosorption. Okay, bone resorption is decreased in this patient, so that's a more mineral will be included. And on the long term it can cause the atypical fracture. I think we discussed this already in the obstetrics, right? Sorry, orthopedics, we have discussed atypical fractures and also gastritis. These are the one important points that you have to remember about the menopause, guys. And also we have discussed about the primary amenorrhea diagnoses and also secondary amenorrhea and their associated conditions. Okay, next, moving on to the four different features. You can see these are the diseases. All diseases has been asked in the previous examination, so let's see one by one. So first, here you can see the patient is suffering from the this is a growth inside. There is a growth that you can see here. So this growth is known as a polyp, right? So there is a polyp in this patient, and this outgrowth is seen where? In the endometrium. Okay, only contact with the endometrium, and they will be consisting of the vessel. This will be consisting of the vessel, and this vessel is going to present it as a post-menstrual bleeding, post-menopausal bleeding, sorry, post-menopausal bleeding. Most common cause. Overall, the most common cause is the post-menopausal bleeding, that is due to polyp only. Okay, and when you do the patient diagnosis, okay, when you do the diagnosis, the best diagnosis is the Doppler. Doppler is the investigation of the choice for this patient, and here you are going to see the feeding vessel, right? As I discussed, there is a vessel, that vessel is causing this bleeding, right? So there will be vessel, that will be feeding vessel will be positive in this patient. Okay, and the treatment is removal. We can simply remove the patient. And what is contraindicated? Biopsy. Why biopsy is contraindicated? There is a vessel, if you touch that, it can cause the bleeding, so biopsy is contraindicated in this patient, right? Next condition. So here you can see this is the endometriosis. So any condition that is severe in this patients, in the human, that is the endometriosis. Any condition they can tolerate, but the endometriosis is one of the worst condition that they have. Why? Let's see. So endometriosis, why this condition is actually happening? For example, the whatever the bleeding, it has to be come through the vagina. Sometimes it is going back. So we call this as a retrograde. So if it is consisting of the estrogen and going back, it can cause the aberrant tissues. These tissues can block at any location. And whenever the patient is having the menses, obviously she is having the uterine pain. But due to this retrograde and this ectopic sites, the patient will be having pain at every site. So that is why this condition not just going to cause the endometrial pain, but it can cause the other structures also. Okay, so the most accepted theory behind why the endometriosis is causing, that is the Samson's theory. That theory is the Samson's theory. He said that it is due to retrograde menstruation. This is due to retrograde menstruation. All right, and what is the most common site? The most common site is the ovaries. The most common site is the ovary of the patient, and followed by the pouch of Dolgus, and also broad ligament of the patient. Okay, and can this involve any other? Yes, it can involve lungs also through the circulation. It can involve the spleen also. Even it can involve the CNS. But all these are rare, fortunately, right? It will be more severe for the patient. So these are the one of the points that you have to remember, guys. Okay, even it can involve the scar also involved, the cesarean section scar also involved. And what is the age group of the patients? The age group of the patients will be around 30s decades will be seen in this patient, and mostly nulliparous. So if you see that family show, so I think Phil, that show, in that show the heroine is suffered from the endometriosis. She has very deteriorating. She also undergone with the hysterectomy due to that condition. Okay, so nulliparous woman, 30s of the age, there will be presentation that the patient will be seen, and most commonly they will be presented with a secondary dysmenorrhea. So the patient will be having the secondary dysmenorrhea, followed by pelvic chronic pelvic pain, chronic pelvic pain, and also they will be having the dyspareunia, the pain during the sexual intercourse, and infertility in fertility conditions, plus adnexal mass. All these symptoms will be presented in the patient. And generally we are going to do the investigation of the choice. Initial investigation of the choice, we will be going uh, for the ultrasound, right? So best investigation of the choice, if you have to choose for this patient, is the laparoscopy. Laparoscopy for this patients. And gold standard, the gold standard for this patient is biopsy. Gold standard is biopsy. If they give laparoscopy with biopsy, you can choose gold standard. If they just give the biopsy, better go for the biopsy only. Okay, that is the best investigation of the choice. And some of the, if you want to see any other structures is involved, for that you can go for the MRI, because soft tissues are best seen in the MRI. And the treatment for this patient is initially NSAIDs, because if you see dyspareunia, pelvic pain, dyspareunia, all these pains can be treated only with the NSAIDs initially. Okay, then we can give the GnRH continuous dose. Why continuous dose? If you give the continuous dose, it will suppress the estrogen, so the pain will be decreased in this patient. So for the fertility, so still the uterus is normal only, so we can go for the letrozole. Letrozole we can give for this patient for the treatment of the surgery. Okay. Next, moving on to the next condition. This is the endometriosis, guys. So let's understand important points about the adenomyosis. So the patient who is suffering from the adenomyosis, they also having the ectopic tissue, but this ectopic tissue is invaded into the myometrium. Okay, only myometrium. So this is our myometrium, parametrium, endometrium. So the tissue is invaded into the only myometrium. Okay, myometrium invasion is seen in this patient. Okay, 1 point. And these patients will be multiparous, not like the other condition. These are multiparous and more than 40 years of the patient. Already the family must have completed for this patient. And the most common symptoms will be, the patient will be having the increased bleeding, not the pain bleeding. This is associated with the increased bleeding, but that patient is having the pain bleeding. And along with that, the patient will be having the abdominal pain, especially the lower abdominal pain, which will be associated with this patient. On examination per abdomen, you are going to see there is a globular, again there is a globular, symmetric and increased period of gestation. Kind of, it is an increased period of gestation. Enlarged mass will be seen on the uterus examination. And also adenexa tenderness is not seen, because there is no lesion in the adenexa. The pain will be um, only seen with the uterus only. That is what the differentiating feature. And the investigation of the choice is MRI, because we have to visualize the patient condition in the myometrium invasion. And again, the gold standard here also, it is the biopsy. We don't have to go for the laparoscopy, just we can go for this condition. And the treatment, best treatment, more than 40 years, right? Already the family must have complete for this woman, and we can go for the total abdominal hysterectomy, and then you can send for the biopsy to rule out any other lesions for this patient. Okay. Next, last but not the least, this is the fibroids. Okay, for the patients of the fibroids, we have the three types. Again, I said this is the serosa, this is the myometrium, this is the endometrium, right? They are the three locations. So if you see, it is coming towards the serosa or it is coming out of the serosa, these are known as a subserosal. These are known as a subserosal. And if it is only concised to the inside, this is known as a submucosal. Most common is submucosal types only. This is the most common overall. Next, this one is the intramural. These are the intramural. And which is more dangerous? This is the subserosal, is the most dangerous. And which is most common to cause the abortions? Submucosal can cause the abortions. Which is more painful? Intramural is painful. Intramural is painful. These are the some factors that you have to remember. Okay. So what is fibroid, guys? This is known as a leiomyoma, and this is most common benign condition, benign tumor of women. Every now and then you can see one in 10 women, they will be consisting of the leiomyoma. And most common risk factor for this patient is the estrogen itself. Early menarche, late menopause, and nulliparity, and high estrogen levels, that is a risk factor. More the estrogen, more the fibroid formation for this patient. It will decrease with the it will decrease as the estrogen decrease. It will increase as the estrogen increase. Right? This is how the patient will be presented. Next, how can you differentiate? We have the FIGO classification for this one. We have the FIGO classification. That is important. Unfortunately, in our most of the FMGE examination, the FIGO classification is not asked, but the name is FIGO classification. Symptoms. The patient symptoms will be, and the patient will be having the chronic pain, okay, heavy menstrual bleeding, and pain is seen in this patient, and this is the regular periods. The patient is having the regular periods will be also seen. On the per abdominal examination, there is a globular mass. There is a globular mass. Also, it look like an increased age of gestation, but asymmetric. This is a asymmetric that you are going to see. Okay, sometimes it is also going to have the retroversion of the uterus. Next, coming to the, there is a high chance it can go for the calcification. High chance it can go for the calcification. Most common calcification is the hyaline. Most common calcification is the hyaline. And second most common is the red. And this red is associated with the pregnancy patient. And what you can treat this patient? Nothing. The treatment is supportive. Just wait for the patient to deliver. After the delivery, you can see. Because during the pregnancy, the fibroid growth is not seen. So we can just move on to the patient only. Investigation of the choice for this patient is transvaginal ultrasound is the best. No gold standard, nothing. Ultrasound is the best that we can go for this patient. And biopsy is done if it is a irregular growth and present even after menopause. Even after menopause, then we have to go for the patient. And the treatment here is the OCPs we can give. If there is a pain, NSAIDs can be given for this patient. And the best treatment is myomectomy. We can remove that tumor. If the family is complete, then we can go for the total abdominal hysterectomy for this patient. So these are the 4 conditions that is important, guys. Sometimes it can be asked in the examination, so should not be forgotten. Next, Mullerian agenesis. So there is a condition, those are Mullerian agenesis. So before we understand Mullerian agenesis, how these are formed, how these Mullerian ducts are formed, so we have to also understand that first. So first, there is a SRY gene. There is a SRY gene. This SRY gene is going to present in the males. It is not present in the females. Okay, let's say this is present in the male patient and this is absent in the female patient. Female person, sorry, not a patient, person. So male patients, when they present with the SRY gene, they are going to have the testis development. So testis is developed for this patient. Testis is going to produce the 2 cells. One is the Sertoli cells, other one is the Leydig cells. It is going to have the Leydig cells. There is a hormones, right? FSH is important for the Sertoli cells. LH is important for the Leydig cells. And Sertoli cells is going to produce the AMH, anti-Mullerian hormone. It is going to produce the anti-Mullerian hormone. Along with that, it is going to also produce the sperms. So spermatogenesis is mainly happening from the Sertoli cells only. And if it is want to stop the action of the FSH, it is going to produce the inhibin B. It is going to produce the inhibin B, so that inhibin B can stop the FSH function. So this is the Sertoli action. Next, Leydig cells. Leydig cells is produced by the LH. LH can help for the testosterone. It is going to helpful for the testosterone production. And the testosterone is going to produce the 2 things. Testosterone is helpful to produce the Wolffian duct. Okay, Wolffian duct. Just remember Wolffian, and this is for the man. Wolffian is for the man. Okay, and it is going to helpful for the male person to develop the seminal vesicles, epididymitis, vas deferens. Okay, it is also going to helpful for the vas deferens and ejaculatory duct. and other side there is a testosterone can convert it as a dehydrotestosterone, and it will be helpful for producing the genitalia is seen with this condition. Okay, this is the SRY is present, guys, and here SRY is not present. So what happens if there is a SRY absent in this patient? Okay, so when there is a SRY is absent, obviously the testis is absent in this patient. So as anti-Mullerian hormone is absent, if the anti-Mullerian hormone is absent, this can produce the Mullerian. Okay, Mullerian duct is produced in this patient, so the uterus is formed. So the patient can have the fallopian tube and the cervix and vagina. In the vagina, it is only have the upper part. So there is no Leydig cells. There is no Leydig cells. There is no testosterone. There is no Wolffian duct. So this is how the female and the male genitalia is produced. Now see, this is due to Mullerian, right? This is due to Mullerian. But in this patient, the Mullerian is not formed properly. So obviously, these are the conditions that the patient will be presented. So let's see what are the conditions. First and foremost, the most common overall, here you can see that is the septated. This is the most common overall. Okay. And the second most common, that is the arcuate. This is the second most common. Okay. And also we have the other types like unicarnate, bicornuate, bicorneus unicolis, and uterus didelphys, asymmetrical bicornuate, vagina septa, uterus normally, vagina is developed. This is the normal one, and all remaining are the abnormal one. Okay, and just imagine from the images you have to differentiate, guys. First we have the bicornuate, we will see, okay, and the septate. So how can we differentiate between these two? Septate, as I said, this is the most common. So this patient with the bicornuate, they will be having the uterus, but there is a two uterus. Okay, there is a two uterus. Two uterus will be seen in this patient, and more on the ultrasound, this is more obtuse. On the ultrasound, this is more obtuse. So this angle is more obtuse, like this. It will be looking like this. So this is how it is going to look. This is the bicornuate. Biseptate, it is developed, but the septa is not differentiated. So the patient will be having again same two uterus. Okay, two uterus will be seen, but it is acute angle. So it is look like this only. On the ultrasound, you are going to look more gap, that is a bicornuate, and the least gap, that is the acute septate. Okay, that is how you are going to differentiate. And the septate is always associated with the recurrent abortions. Recurrent abortions is seen in this patient. And best outcome, best outcome like pregnancy can have, that is seen with the arcuate. In the arcuate, prognosis is good for this patient. And you also have the unilateral unicornuate. This unicornuate can develop the endometriosis for this patient, and transverse lie is not possible because of the unicornuate. And another point that you have to remember for the unicornuate, there is a unilateral renal anomalies which will be associated here. That is a one thing. And best investigation for overall all this, the best investigation is the laparoscopy, okay, and the hysteroscopy. That has to be best for this patient to differentiate. These are the some important points about this condition. Next, here you can see the name itself, you are all familiar this condition, polycystic ovarian disease. Okay, polycystic ovarian disease. Polycystic ovarian disease, this is now known as a PMOS. Okay, multiple endocrinopathy. That is why they changed this name as a multiple system disease. So the patient who is suffering from the PCODs, the patient is mainly affected by this polycystic ovaries, right? One point. And another important point that you have to remember, that there will be diabetes mellitus due to insulin resistance. This is due to insulin resistance. And high androgens, there is a high androgens production. This can cause the hirsutism in the patient, and decreased follicle stimulating and decreased LH. So there is a folliculotoxic, no follicle development, because again androgen kill the folliculotoxic. Patient is having the infertility, obesity, okay, due to the insulin resistance, okay, irregular cycles, all this will be seen in this patients, right? So how we are going to treat this patient, how we are going to treat this patient, sorry. So for the patients of the insulin resistance, all this condition, first we have to go for the laboratories for this patient, okay, labs. So on the labs, most of the times FSH is normal, guys, but the LH is decreased in this patient. Okay, FSH is decreased, so FSH is normal, LH is increased. LH is increased. Okay, the ratio will be 1:2. The ratio of the FSH and LH will be 1:2. And so as androgens, so androgens derivative, this will be also increased. Testosterone, due to androgens, testosterone is increased. Due to insulin resistance, the fats can cause the increased LDL. Again, some androgens can be converted as a estrogen, so this is also increased in these patients. Okay, and what are decreased? Progesterone is decreased. Progesterone is decreased in this patient. Okay, and also binding proteins and globulins has decreased. Okay, these are also decreased, right? FSH is most of the times is normal in these patients. Next, go for ultrasound diagnosis. On the ultrasound, you are going to see 12 follicles, more than or equal to 12 follicles, and all are around 2 to 9 mm size, 2 to 9 mm size, and ovary size will be more than 10 cc size that you are see, and this criteria is known as a Rotterdam criteria. This is a Rotterdam criteria, commonly used criteria over the time. And Rotterdam criteria, one point is ultrasound, second point is patient is having the menstrual problems, third point is that the patient is having the high androgens. Any one is present, we have to diagnose that the patient is present with this condition. Okay, one or two, we can consider this as a PCOS. Next, treatment. We have multiple conditions here, right? So first we have to address insulin resistant with the drug metformin. Metformin is given for this patient. Irregular cycles, OCP is given for this patient. Androgen problem, spironolactone can block the androgens, right? Infertility, letrozole is given. Okay, clomiphene citrate is not that much. And overall, the best treatment for this patient is the lifestyle modification has to be done for this patient. So this is how we are going to treat this condition. All right, next, moving on to the uh, different types of the uterine prolapse. This is the condition of the prolapse. So let's see one by one. This is how normally, this is the bladder, uterus and the rectum. If the bladder is coming pushing towards the back side, that means this is the anterior wall, this is the posterior wall. So the posterior part of the bladder is pushing the anterior vaginal wall. So we have to do the treatment for this patient is the anterior colporrhaphy. Anterior colporrhaphy. So this is the best treatment and overall treatment that we are going to do. Uterine prolapse. The uterus is directly coming downwards through the vagina. Rectoprolapse. Rectoprolapse means anterior rectal wall is pushing the posterior vaginal wall. And for this patient, for the rectocele or the rectal wall, we can go for the posterior through the vagina. We are doing this surgery. So we call this as a posterior colpoperineography. This is the treatment that we are going to do for this patient. Next, enterocele. Enterocele means the bowel is coming for this patient. And for this patient, the Mechal, this is the Mechal caldoplasty. mechalcaldoplasty is done for this patient. So this is the surgery choices for this condition that is done. Next, moving on to the patients with the uterine prolapse. Uterine prolapse. So uterine prolapse, what is the causes? In mostly in our world, in our India, that is birth or labor trauma. During the labor, this is caused. And multigravida, in our olden grandmothers, you might have seen more than 6, 7, 9, that is a multigravida. And also aging, elderly women, age, and females having the more prone to pelvic issues. So elderly females, that is going to see. And here, the classification we follow is the POPQ. And this POPQ will follow the vaginal length. POPQ will follow the vaginal length. Don't have to know about the entire what about the POPQ classification. So we have to know about the surgery processes. For example, the mother is want to bear the child, she want to have the child, and she is having that nulliparity. Then we go for the sling surgery. This is known as a sling surgery. Sling or Shirodkar, we call this. Right? Next, if there is no family, that means family is complete and she doesn't want to also have the father family. Then this is a Fother grill, okay, or Manchester surgery, Manchester repair. They don't ask what is the total procedure, at least you have to know about the name, guys. Elderly women with menopause, then you can go for the total abdominal hysterectomy. Elderly woman, again menopause plus comorbs, she is having the comorbids. Then we go for the Lefort colpoclesis. Lefort colpoclesis. Patient is pregnant or patient is more than 70 years. There is no chance to do the surgery because is already going to be the palliative treatment. For this patient, we are going to use the ring pessary. Ring pessary for this patient. So these are the treatment of the choices for this condition. Next, we have the different conditions that you can see here. So first one here you can see just, so this is the bladder. This is the condition where you are going to see the uterus. Okay. Next, this is the bowel. Okay. We'll be seeing here itself. So let's see, guys. So the patient is having the vesicouterine. Vesicouterine means the patient is having connection with the bladder and the uterus. Okay, bladder with the uterus. This is the vesicouterine. Here there is a involvement of the vagina. Sorry, involvement of the bladder plus uterus. Next, vesicovaginal. Vesicovaginal. So here you can see this is the connection. This is the vagina, this is the bladder. So this is between the bladder plus vagina. Next, urethrovaginal. Here you can see this is the urethra, this is the vagina. So here it involved urethra plus vagina. Next, rectovaginal, from the rectum. This is the rectum involvement plus the vagina. And also there is a other one, that is the ureter, ureterovaginal cyst, that is also seen in this patient. So these are the different conditions. But how we are going to diagnose this patient? With the test of the methylene blue test. With the test of methylene blue test. So methylene blue test, which will be consisting of the methylene blue color, 3 cotton balls will be presented. 3 cotton balls. Okay, and 3 cotton balls is kept in the vagina. Kept in the vagina. So how we are going to differentiate? For example, let's take one by one. Vesicule plus vaginal fistula. So vagina plus bladder fistula. So obviously the patient is having the urine, continuous urine will be seen in this patient due to the bladder involvement, right? So when you put this vaginal, the middle one, so one is upper and here, and the third one we are going to place upper vagina, middle vagina, lower vagina. So the middle vagina which will be having positive, and the first one is not seen, so that is no problem with the ureter or not problem with the uterus. So the directly the fistula is in the vagina. Next, coming to the uretrovaginal fistula, and here urine is coming only on voluntary, because there is a voluntary, right, involuntary and involuntary, and here also there will be positive, but where lower cotton lower cotton ball you are going to see in this patient. So this is how we are going to differentiate from the uretro and the vaginal. If you see the feces, that is a rectovaginal. If you see the continuous urine, that is the bladder or the urethra involvement, right? And what is the most common cause for this patient? The most common cause for this patient is the birth trauma. And if they present less than 24 hours, you have to do the repair. If they present more than 24 hours, then 6 weeks after you have to do the repair. And the pregnancy after this is contraindicated at least for 1 year. If ever the patient is pregnant, then go for the LSCS surgery. That has to be done for this patient. So this is the vesicoureteral condition. Next, some cancers that was just important to know, guys. Let's understand some points. That is endometrial cancer. Endometrial cancer, and this is associated with the adenocarcinoma type. Most common is the adenocarcinoma type, where you see more than 50 years post-menopausal patients, right? Post-menopausal patient. Obviously, there is a history of estrogen and some of the conditions like Cowden syndrome. All this will be, patient will be having this condition, right? And also Lynch syndrome. This question is asked. Obesity, patient is having the diabetes mellitus. Hypertension can cause. Smoking, more the estrogen production as we discussed again, and different types of the endocrine conditions from the childhood. PCOD can cause, because estrogen is increased in the PCOD also. Patient has never had the pregnancy. Nulliparity can cause. Tamoxifen can cause. Okay, risk factors can be asked in the examination. So stage 1 patients, stage 1 patient, since she is already, the patient is having the lesion, you can remove the surgery only the part of the lesion, okay, only the part of the tumor that you can remove. If the patient is already having the stage 1 is progressed, already menopause, right, we can go for the total abdominal hysterectomy plus bilateral salpingo-oophorectomy can be done for this patient. Okay, stage 2 plus stage 3, this is progressing type. So lymph node involvement is also seen in this patients. Here you can see. So this is the stage 1, only confined to the endometrium and the myometrium. Stage 2 involve the surrounding structure cervix. Stage 3, that is already involving the surrounding lymph nodes. Stage 4b, it is already metastasis has been happened. So stage 2 and 3, total abdominal hysterectomy, bilateral salpingo-oophorectomy, but lymph node dissection has to be done for this patient. Stage 4, here you have to do the debulking surgery. Here the surgery name is the debulking surgery, followed by you have to go for the chemoradiation. Chemoradiation has to be done for this patient, right? Next, moving on to the cervix. Cervix cancer, this is a benign condition that we are discussing. This is a pre-malignant condition, right? We have the different types. CIN, cervical neoplasia 1. What happened here? The involvement is less than 1/3. The involvement is less than 1/3. CIN2, it is more than 1/3 but less than 2/3. CIN3, it is more than 2/3. Okay, it is more than 2/3. The patient who is suffered from this, the CIN, is most commonly associated with the HPV. Okay, this is most commonly associated with the HPV. And secondly, this is a dysplasia, not a neoplasia. This is a dysplasia conditions. Okay, this is a dysplasia. Consider this as a pre-malignant lesion. And where is the location? The most common location is the squamocolumnar junction. Squamocolumnar junction. Right? Next, what is the age group? 20 to 30 years of the age groups, pre-malignant conditions will be seen in this patient, right? And you can go for the surgery like LEEP or the cryosurgery can be done for this patient. Next, moving on to the cervical cancer. Cervical cancer, rather than important questions about the cervical cancer, there are multiple questions that is asked. What are the causes? Causes, first one is the human papilloma virus 16 and 18. These are due to E6 and the E7. E6 on the P53, E7 on the RBG. These are the two genes that will be involved, and this can produce this cancer. And from when you are going to do this screening for this patient? So the screening for this patient has to be done from the 21 years of the age until 65 years. So we are going to start with the pap smear. We are going to start with the pap smear and the HPV DNA test. HPV DNA test is done, and biopsy if you suspect the condition. This is for the urban areas. Okay. So in the rural areas, we are going to do the pap smears and the Lugol's iodine visual aids we are going to see in the rural areas. What is the treatment for these patients? The treatment for this patient is prevention. Best is the prevention can be done with the help of HPV vaccines. With the help of HPV vaccines. And the most common one in India nowadays is using the Gardasil vaccine is giving for the patients. Next, ovarian cancers. Just know about what are the names of the ovarian cancers. You have the different types of the ovarian cancers that you can see. If it is a surface epithelium, either it is a serous or the serous adenoma. And if it could be due to oocytes. It is a germ cells tumors like this germinoma or the yolk sac tumors. Granulosa cell tumor, theca cell tumor, fibroblast ovarian fibroma, and the primitive gonadal, it is a Sertoli-Leydig cells that will be associated in this patient. And the important point about these conditions, the cervical cancers, is that what are the features that you are going to see in these conditions. For example, the features such as conditions with the patients of the dermoid cyst. So if there is a teratoma or the dermoid cyst patients, this is the most common germ cell tumors. So you are going to see the hair, teeth. Okay, these kind of structures will be seen inside the tumor. Okay, that is will be seen. Next, coming to the dysgerminoma. In the dysgerminoma, you are going to see lymphocytes, increased lymphocytes that will be seen in this patient. And granulosa, called Exner cells. And yolk sac tumors. In the yolk sac tumors, you are going to see the rosette shapes. Okay, that is known as a Schiller dual bodies. Those are Schiller dual bodies that will be seen in this patients. Okay. Next, these are the important points that you have to take note, guys. So this may be asked in the examination. So overall, these points, like last one, we will be discussing about the Meige syndrome and also pseudo-Meige syndrome. What is the Meige syndrome and the pseudo-Meige syndrome? So the patient who is suffering from the Meige syndromes, there will be right effusion. Okay, right effusion in the lungs, right pleural effusion that you are going to see. Along with that, ascites, plus the ovarian tumor. So same as here also. Same, the right side lung effusion plus ascites plus comorbid you are going to see, not the tumor but the comorbid is seen in this patient. Okay, so this is some important points about the all the conditions that you have to learn from the gynecology, guys. So please do revise. And again, so those who are already subscribed for these books, please do go down the link of the description of the Google Drive and you can access this PDF file. so as others also you can access this file, guys. So don't forget to subscribe and share with your friends, and do like this video so that it will reach the more students. Happy preparation, guys. See you all on the next video.